session. Good afternoon, everyone. Good afternoon, uh, respected seniors, dear friends. At the onset, I would like to thank the organizers, especially Dr. Vinay Jagnany, for this wonderful session in the afternoon today, for giving us this opportunity. I'm going to talk on diabetic foot evaluation, which is a very, very important topic today. And it's one of the very, very common complications which we see in day to day practice. I hope I'm quite visible and my slides are good seen to everyone. Can I
Yes,
proceed?
sir.
Yep.
Yes, sir. Sure, sir.
So the most important thing is why diabetes with diabetic foot ulcer is very, very important. Like the IDF, the International Diabetic Federation estimates current population of 387 million diabetics, and by 2035 it will be 592 millions. And India is at the second place at the moment. And the annual incidence of diabetic foot ulcer is 2%, and the recurrent rate is 30 to 40%. Peripheral neuropathy affects 50%, and around 8% of the diabetics have peripheral arterial disease at the time. And the biggest problem in our country is that the peripheral neuropathy causes painless ulcers, which the people don't care about unless they land up with serious complications. Amputation rate in diabetic foot ulcer is 33%, and patients with amputated limbs undergo contralateral amputation within 5 years in 58%. So you can understand this is a huge, huge burden, and every 22nd, a diabetic undergoes an amputation worldwide. Incidence of diabetic foot in India is no less. Lifetime risk of a person with diabetes having a foot ulcer is 15%. The prevalence of foot ulcer in diabetic attending a diabetic foot center is 3%. And the prevalence of foot ulcer among outpatient and inpatient diabetic patients hospitals in rural India is 10%. So you can understand it's very, very huge. 10 out of 1 people visiting a rural hospital are having diabetic foot ulcers. And prevalence of peripheral vascular disease in diabetics below 50 years of age is 3%. And the prevalence of PVD is peripheral vascular disease in diabetics above 80 years of age is 55%. So again, this is again a real big challenge because it's very, very difficult in this age group people to do an angiography and to look at the site of lesion and to actually revascularize the peripheral vascular disease patients. Patients with type diabetes for 1 decade who suffer from diabetic foot is almost 15%, and patients with diabetes who lose at least a part of their leg due to diabetic foot year is 1 million. So leg amputated every year in India is 1 lakh. So you can understand it's a very, very huge problem in our country. And let me tell you, 50% of the patients with diabetes who are admitted in the hospital have diabetic foot ulcer or some form of diabetic foot complications. The burden of diabetic foot is 85% of limb amputations are preceded by trivial foot lesions, which can be easily prevented and treated very, very intensively. Even the ADA 2016 recommendation for foot care suggests to perform a comprehensive foot evaluation each year to identify risk factors for ulcers and amputations. Examination should include inspection of skin integrity, assessment of musculoskeletal deformities, neurological assessment for high suspicious lesions using 10 monogram filament, pinprick, and VPT. We all are doing in day-to-day practice. Ankle reflexes. ADA also recommends vascular assessment by palpation of pedal pulses. ABI, that is ankle brachial index, for everyone more than 50 years of age, or patients who are having a high risk, for example, smokers, or who has a family history of premature atherosclerotic disease. And high risk patients, especially with prior amputation or foot deformities or PAD, then poor glycemic control, visual impairment, peripheral neuropathy, cigarette smoking, etc. So all these high risk patients should be educated about risk factors and appropriate management. So education is the key factor. Selection of footwear and footwear behavior at home should also be discussed. Well-fitted walking shoes or athletic shoes should be suggested with cushions at the feet and redistribute pressure. People with bony deformities or bone advanced disease may require custom fitted shoes. This is also very, very important. Diabetic foot care is an integral part of complete diabetes care, diagnostic care, preventive care, and therapeutic care. Now, this is one area why I'm talking this is anyone who is actually practicing for diabetic patients as a specialty. They can easily create a small center in their clinic for diabetic foot specialty. The diagnostic care, the preventive care, and the therapeutic care, all three things important included. Now, most important thing is diabetic foot questionnaire. Have you ever had a sore or cut on your leg that took more than 2 weeks to heal? Have you ever had foot ulcers? A patient will say, डॉक्टर साहब, I have diabetes for last 15 years, लेकिन मेरा तो घाव सूखने में टाइम नहीं लगता है. Now they are very very proud of it that मेरे को diabetes का ज़्यादा लफड़ा नहीं है. In spite of keeping a blood sugar of 300 and 400, HbA1c more than 10, they still feel very good that उनका घाव सूख जाता है. But warn them that out of 10 wounds, 8 or 9 wounds are okay, but one wound can become bad and that can lead to a lot of complications. So you have to educate these people by asking them, have you ever had foot ulcer? Have you ever had an amputation of toe, foot, or leg? These are very, very simple questions. Even you can talk to your patients while examining their pulse and examining their blood pressure. You can talk to them. Current foot or leg problems. Do you have an ulcer, sore, or blister on your feet at this time? Do you have blood or discharge on your socks? Do you have any calluses on your feet? Do you have any numbness, tingling, pains, and needles or itching sensation in your feet? Do you have any tightness, heaviness, pain, or cramps in your feet or legs? Especially, you can also ask for night cramps, especially when they sleep because of early peripheral vascular disease, they get night cramps or night pain. So can you reach and see the bottom of the feet? Because this is again a real big problem when a patient has got limited joint movements, they cannot. Do you examine your feet every day, once a week, 2 to 6 times a week when I have problem? So you can always ask these very, very small, simple questions when you are actually talking to your patients or examining them. You can talk to them regarding their feet. Diabetic foot care. Do you use any moisturizer cream on your feet or something like हमारे यहाँ कड़वा तेल use करते हैं हमारे बिहार झारखंड में, it's very very popular. Some people even use, I'm talking about the mustard oil. That is what is called as the locally as more popularly as kadwa tel. Is very very commonly used in our part of the country. Even some people use coconut oil. Some people put camphor into the coconut oil and they use it. So these are important moisturizers which are very very popular in our part of the world. Do you cut your nails on your own or do you take some assistance of family member or caregiver or foot care nurse or a podiatrist? So these are very very simple questions that you can talk to your patients. And what you can do is, whenever you're talking about diabetic foot on a particular visit, you make a note that diabetic foot questionnaire has been done, so that next time when the patient comes, you can talk about the diabetic retinopathy and the diabetic kidney disease or something like heart failure symptoms. So step by step, you can always cover all the possible complications of diabetes. You need not talk all the possible complications in the first visit, which is very, very tedious job. Even the patients get bugged when you ask too many questions to them. What kind of shoes do you wear? Pointed shoes, like your Oxford shoes, which are very, very common these days, sandals, shoes made up of leather or canvas, broad rounded shoes, flip-flops, high heels, athletic sneakers, runners, specially customized shoes. You can ask all these things. What kind of socks do you wear? Cotton, knee-high, nylon, wool, elastic, free tops. I mean, these are all very, very simple things. Again, they will tell you many people don't put on socks even when they put while using their shoes. So that is also a real challenge in our country. People just wear shoes without any socks as well. So that is also a very, very important history. Safety and prevention. Do you ever soak your feet? Yes or no? There are people who soak their feet very, very commonly. Do you always test water temperature before putting your foot into it? Do you use medicated products of warts, corns, or calluses? There are a lot of people who do self-surgery of their warts and corns and calluses and then land up with infection. Do you put moisturizing creams or lotions between your toes? Especially if they have a dry web space, they can get cuts and they can land up with fungal infection and secondary bacterial infection. Do you ever walk around in your bare feet? Which is again very very common. हम घास में खाली पैर चलते हैं ना, हमको बहुत अच्छा लगता है. And there are a lot of benefits of walking on grasses, empty feet. So without any footwear. So that is again a very, very customized approach in our country. Again, you can, do you ever wear shoes without wearing any socks? Do you always inspect your shoes for foreign object or torn linings? Do you use hot water bottles or heating pad on your feet? Do you sit with your legs crossed? Do you smoke? So these are important questionnaires which are being suggested by American Diabetic Association. Have you ever attended a class on how to care your feet? Then have you ever read any handouts on foot care? So these are very, very important education material that can be shared with your patients, and you can talk to them. They will tell you, and they can actually change and learn about it. So these are the type of footwears that patients are using, which should not be worn out footwears. It's again not uncommon in your clinic. This is again not recommended because patients can actually have worn between the web space, and the chappals are not recommended. Similarly, the slippers are not recommended. You have to walk for long distance. This is only good when you are at home. Then this type of socks and footwear along with it is not recommended. So you have to actually see the patient. So ask your patients to get into the clinic with shoes and socks inside. Many a times there is a tradition that patients remove their shoes while entering to your clinic, and they don't get their shoes. So you can't share ideas with them. Foreign body injuries are again very, very common. And if your patient comes with alta on their feet, you cannot examine them well. So for the next time, you should tell them, when you come next time, keep your feet clean, and don't ask them not to wear all these things because they can cause foot ischemia, digital ischemia. This is what people use it. If there is some edema or injury because of this, it can lead to loss of toe. So this is what is again very, very common practice in our part of the country. So inspection of foot is very important. Again, I tell you, inspection of foot you can do while actually talking to your patients. You can examine the feet, and you can do multitasking at one time. So you can see all these things. This is what is the most important thing, that you should ask all your patients to lie down and remove their footwear and socks and examine their feet. This is very, very important. This should not be ignored in day-to-day practice. This is one thing which gives you a lot of ideas about the present foot condition and the chances of getting foot problems later on as well. So you can actually decide their treatment accordingly. Loss of hair on the dorsum of foot and dependent tumor is also a feature of autonomic neuropathy. Early feature of autonomic neuropathy, mottled skin, diabetic dermopathy, shoe bite. All these things definitely needs to be taken. And it's a one-time things can be seen very, very easily. So this is a type of shoe bite you get, especially if a patient has come with a new footwear. And during this rainy season, a lot of patients wear these plastic shoes, which are not again uncommon in our part of the country. They wear plastic shoes and they get these shoe bites and they come with foot ulcers. Cracked heel is again a feature of autonomic neuropathy because of dryness. And this is very, very common in our country and very ignored as well. Same here with claw toss. Clawing of toes is because of sensory motor neuropathy. There is loss of the interosseous muscles that leads to clawing of the toes. So this is again hallux valgus, which is again more sensory motor neuropathy. This is also a very, very important high risk foot, and which is very, very common. We should actually look into it. Caves is also not uncommon, and this is again because of autonomic neuropathy and associated sensory motor neuropathy. Both callus, this is again, we see a lot of patients with callus, and they are very, very ignorant about it. They keep doing a self surgery. They cut it. Sometimes they are successful in removing some dead tissue, but many a times they land up with infection because of cutting the live skin. So this is again a bursitis of the lateral malleolus. Even bursitis is very common because of we actually sitting पालथी मार के जो हम लोग बैठते हैं, उसकी वजह से for long time it can lead to bursitis like this. This is how it is on the lateral malleolus. Diabetic dermopathy is again very, very common, something like Schwarzbach phenomenon because of drugs like amlodipine, which causes mild edema, vascular dilatation, and this causes skin changes. Many times you have to ask your patients to stop taking drugs like amlodipine, or they respond to vitamin C and vitamin E, and you should ask your patients to raise your limb while lying down. This is again diabetic dermopathy, which is again not uncommon. Interdigital mycosis, this is what I was talking about between the web space. And this mycosis, if not treated well, can get secondarily infected, and that can lead to problems. Onychogryphosis is again a big problem, which is very, very common. We can only see all these things if you examine the feet, ask your patients to lie down, remove their socks and footwear. Ingrowth toenails is again because of improper cutting of nails, and they actually grow with inside the skin, and they cause ulcer. Onychomycosis is again almost a lot of patients who get with onychomycosis, and if you don't treat them, this is paronychia. This is again very, very common. This is what is called as a web space ulcers. Swelling, this is what is the earliest feature of abscess and cellulitis, which you see in clinical practice. Many patients, they don't have pain, and they say that their kidney is fired, their foot is swollen, and then you will see that it has a local warm redness and swelling, and you will find that there is a collection and abscess. High risk contralateral foot. This is how it is. This there is a amputation of grade 2 in the right foot, and there is a infected neuropathic ulcer at the head of the first metatarsal on the left foot. So palpation is again very important. Peripheral pulsation, especially dorsalis pedis, posterior tibial, you can feel, even anterior tibial, you can feel. Bony, you can also try to feel the bounding pulsation, which is an early feature of autonomic neuropathy. Even that should be looked into. Bony prominence is also very, very common with someone having a hallux valgus, or someone having vesting of small muscles of the foot. Limited joint mobility, also known as chiroarthropathy, is again a very, very common condition, and that leads to basically excessive pressure while walking, and that can lead to cracks over the foot and ulcer. Temperature is also very important. So this is what I was talking about, limited joint mobility at ankle. Then limited joint mobility again at ankle. So patients don't not being able to dorsiflex better. This is at the level of grade 2. So neuropathy, you need to see signs, motor neuropathy, high medial longitudinal arch, something like this. They have a very high arch, atrophy of small muscles, foot drop, abnormal gait. So these are things which are very, very common clinically, and we need to know and see in our day-to-day practice. What you can do at your clinic is you can use this pressure sensor machines that can actually see your pressure points at different levels, and you can actually tell your patients that you need a special footwear to release those pressure points, and they will have less chances of foot problems in future. So this is one test which can be done very, very easily in your clinic, a very small digital instrument where you ask your patients to stand and you get a lot of data. You can see the pest cavers and all the stuff very, very easily. There's another patient, Vasan. You can see that patient has got clawing and patient has got high pressure points, and that is why he's very likely to get ulcers in the future. You can give them special footwears, and that is going to help them. Autonomic neuropathy is again a big problem. Dry skin, fissuring neuro, and distended veins. Since Semenstein points, monofilament test can be done. 120 Hertz tuning fork is very simple. Pinprick is very, very simple. Ankle reflex can be done, and VPT, if you have a biothesiometer, you can use the VPT. But rest of the tests you can do at your clinic is a very, very simple, cost-effective way. The monofilament. I'm attending a meeting yesterday. I heard Dr. Andrew Bolton, who is a specialist in diabetic foot management, coming all the way from Manchester. And yesterday we had a very good time celebrating the diabetic foot campaign, which has been going on. And what he said was, suggest someone which is very, very cost effective and can be done very easily. And it's just a 1-minute test in your clinic. You do a monofilament test, you do a tuning fork test, a pinprick test, and an ankle reflex. Everything can be done. The total examination can be done in 3 minutes, and you don't have to spend much time. This is how we have a biothesiometer in our clinic that can be used, and you can actually give them report. These are the normal values, and for the right and the left foot, these are very, very simple. Only do it in patients who have got a lot of symptoms and who are having a chronic diabetes. There you can use it. Otherwise, you need not do it in all your patients. They don't spend a lot of time in your clinic. Similarly, you can do a Doppler study in your clinic. It's also very, very simple to look for uh, uh, posterior tibial artery in this case, and in dorsalis pedis artery. And you can do an ankle brachial pressure index, and the normal uh, ankle brachial index should be more than 1. Anything less than 0.9 is an ischemic ischemia is present, or someone having less than 0.5 is severe ischemia. It can, gives a false positive result in people who have calcified arteries. These are the type of data which you can collect in your clinic and give it, tell your patients or warn your patients and put them on preventive therapies. Examination of foot ulcers, foot infections, and neuroischemic foot is also very, very important, and it's not difficult. Again, 2 to 3 minutes time you can devote, and you will get all your answers. Always remember to investigate for other micro and macrovascular complications simultaneously, because we know that all these three complications, neuropathy, retinopathy, and nephropathy, are hand to hand together in all your patients. So if you see someone having a severe neuropathy, you should also look for microalbuminuria or macroalbuminuria, or in fact even retinal examination to look for other complications. So preventive care is what is very, very important. An ounce of prevention is worth a pound of cure. Ben Franklin said long time back, and this still holds good. Patient education is the most powerful weapon we can use to change the world. And let me tell you, the prevention of diabetic foot is what is very, very important. And both we as a doctors should actually examine and tell your patient that you're having a high risk foot. You need some care. You need a special footwear. You need special care being a diabetic to your feet. We've actually missed to communicate everything in the clinic for the first time, but it's very, very important. And just make a small note, foot check. That is all you have to write, foot checking done. So you can make a note that will tell you that you have done this job this time. If the patient comes after 2 months, you need not spend the same time again and again. You can do it once in 6 months or once in a year. So this is what is important, that every visit, you need not do a foot examination, but make a note that you have done once. So what are the do's and don'ts? Check your feet daily for cuts, blisters, bruises, color changes, swelling, ingrowth toenails, and open sores. Always protect your feet. Wear appropriate footwear inside or outside. Pricking your feet may cause serious wounds. Before wearing foot shoes, check inside the stones, pebbles, or any sharp objects. Wear socks and shoes. Make sure they are not tight. Wash your socks daily, but new shoes at the end of the day, that's when your feet swell. So whenever you buy a new footwear, always take the size in the evening, because of the swelling in the till by evening, you have a higher size of footwear. Then if you have to remove your shoes, like in religious places, visit the place by morning or late in the evening. Hot grounds can blister your feet. Always wash your feet with soap and water on coming back home. Take care to wash between toes. Dry them carefully. Use lotion oil. Cut toenails straight across the file, and file the sharp edges. So you need not cut at the angles. This is what is very, very important. At the corners, you should not cut it like a curve. You should make it like a straight cut. Have your feet been checked periodically by a doctor? So you should tell your patients, doctor, you haven't checked my feet for last 1 year, so do it. Please do it again. So this is a type of education you have to give. Keep wounds covered with a clean dressing. So don't walk barefoot anywhere outside or inside. Don't wear tight, torn shoes with. So these are very, very important messages which you can give while talking to your patients. Even you can give a template, or you can keep an educator in your clinic or your compounder and give a printed material in a local language, in Hindi or English, and they can definitely speak to them that read this in front of me. This is what is very, very important. So what are the warning signs? Your foot becomes painful, your foot becomes noticeably red or develops any discoloration. A part of whole of foot becomes unusually hot. Your feet smells bad. Your feet have an open sole of blisters. You feel generally unwell with nausea and high temperature. You have unusual difficulty keeping blood sugar levels under control. So this is what is all I have for everyone for today. That diabetic foot is a real big problem, and we need to educate all our diabetic patients about the problems of diabetic foot. How can we prevent it? and how they can take care of their feet and how they can reduce the burden of diabetic foot infections in our country. This is the time. This is the time of cultivation during rainy season. Most of the farmers or people who are working in the city go to there for farming, and they go inside the farm without any footwear for plowing the seeds and the crop. And this is again a real big challenge. So people who are coming from villages or farms, you should ask them to put on comfortable boots, the gum boots, that will actually prevent injury, and that will also help in reducing the burden of diabetic foot. And you should always tell them that whenever they are back from their farm, they should check their feet thoroughly on a daily basis and clean their toe spaces on day-to-day basis. So I thank everyone for your kind attention, and together everyone achieves more. And the mission is zero amputation rate. This is what actually we are looking forward. So I thank you all for your patient listening once again, and I thank the organizers for this meeting, and I also thank the Clernet for actually giving this platform for today's meeting. Thank you very much.